Good morning, everyone. I am Dr. Shrishty Agrawal from Jawaharlal Nehru Medical College, AVBRH Hospital. I am presenting on topic cardiac magnetic resonance imaging of myocardial infarction and cardiomyopathies. Aims and objectives to detect and assess myocardial infarction and evaluate cardiomyopathies and its causes in correlation with clinical finding in 2D echoes, to detect and assess imaging features in acute and chronic myocardial infarctions and cardiomyopathies, to quantify infarct size by delayed enhancement cardiac magnetic resonance imaging, to differentiate between ischemic and various non-ischemic forms of myocardial injury, to correlate cardiac magnetic resonance finding with clinical and 2D echo finding. The study center for my study was Acharya Vinoba Bhave Rural Hospital, Savangi. Study design was descriptive prospective cross-section study. We have used three Tesla MRI machine and various sequences of cardiac imaging was used. Introduction. Myocardial infarction is a leading cause of death worldwide. Cardiac magnetic resonance has a unique ability to assess a global and regional left ventricular function, quantify infarct size with late gadolinium enhancement, assess the status of microvasculature by identifying microvascular obstruction, and evaluate the area at risk with T2 weighted imaging of myocardial edema. The use of contrast enhanced cardiac magnetic resonance for first pass perfusion and late gadolinium enhancement is a powerful technique for delineating areas of myocardial ischemia and infarction. All patients undergoing cardiac magnetic resonance for detection and assessment of myocardial infarction and cardiomyopathies were included. Patient having history of cardiac pacemaker, metallic implant insertion, and metallic foreign body in situ, and patient having history of claustrophobia were included. My sample size was 25 cases. We have included various cases of cardiomyopathies like hypertrophy obstructive cardiomyopathy, dilated cardiomyopathy, postpartum cardiomyopathy, 5 cases of myocardial infarction, and many cases of rupture of sinus of Valsalva, cardiac hydrated, rheumatic heart disease, myocarditis, left atrial myxoma, mild tricuspid regurgitation, global hypokinesia with bilateral atrial enlargement. The first case is of 21-year-old male patient came to the casualty in morning with history of drowsiness and sudden fall, loss of consciousness and pulselessness. The first image is four-chamber view, which shows significant interventricular septal thickening measuring approx 26 mm. The second image is short axis cine imaging. In this, we can see hypokinesia of mid-anterior septal, mid-inferoseptal, mid-apical, anterior, inferior, lateral, and apex. The third image is short axis T2 stir image, which is showing enhancement suggestive of myocardial edema. The fourth image is late gadolinium enhancement short axis image showing patchy nodular enhancement suggestive of fibrosis. So, the presence of severe septal hypertrophy along with patchy late gadolinium enhancement and myocardial edema is suggestive of hypertrophic cardiac myopathy with area of myocardial injury. The second case is a 45-year-old male patient with complaint of chest pain, dyspnea, giddiness since 15 days. The first image shows significant, which is a four-chamber view, significant interventricular septal thickening with S-shaped narrow left ventricle. The second image is a cine imaging, short axis, showing showing dynamic cardiac motion, systolic anterior motion of the mitral valve and causing left ventricular outflow tract obstruction. The third image is three-chamber view. In this, we can see systolic anterior motion of the mitral valve, which is causing left ventricular outflow tract obstruction. Fourth image is late gadolinium enhancement image, um, which is showing nodular enhancement in the papillary muscle suggestive of fibrosis. So this is a case of septal hypertrophy with S-shaped left ventricle cavity, systolic anterior motion of the mitral valve causing left ventricular outflow tract obstruction. Late gadolinium enhancement shows papillary muscle fibrosis. So this is a case of hypertrophy obstructive cardiomyopathy. This is a third case, which is a case of 75-year-old male patient with male patient present in OPD with following complaint like chest pain, breathlessness, palpitation since last 2 to 3 days. The first case is four-chamber view showing hypertrophy of the left atrium and the left ventricle. The second image is late gadolinium enhancement image where there is a transmural infarction in the mid-anterolateral, mid-anteroinferior, apical, lateral, apical, and apical inferior segment. There is the third is cine imaging. In this, we can see tricuspid regurgitation, mitral regurgitation with akinesia seen in mid-anterolateral, mid-anteroinferior, apical lateral, and apical inferior segment. The fourth image is again a four-chamber view showing hypertrophy of all the four chamber of the heart. So this case shows cardiomegaly with transmural infarction on late gadolinium enhancement, thinning and akinesia of the affected segment indicate chronic MI with non-viable myocardium. Coming to discussion, patient prognosis depends on left ventricular function, infarct size, the status of microvasculature within the infarct zone, the amount of salvage myocardium after reperfusion. As a result, patient risk stratification after an acute MI often include a multimodality imaging approach with echocardiography and a cardiac magnetic resonance imaging. In chronic MI, CMR, evaluation of transmurality of infarction relates to the likelihood of functional recovery of dysfunctional myocardium. The use of contrast enhanced CMR for the first pass perfusion and late gadolinium enhancement is a powerful technique for delineating area of myocardial ischemia and infarction. Coming to conclusion, cardiovascular magnetic resonance provide the opportunity for comprehensive evaluation of patient with history of MI with regard to characterizing the extent of disease, impact of left ventricular function, and degree of viable myocardium. Diagnosis of MI also impact clinical management and available data indicate that even a small infarct potent worse short and long-term prognosis. These are my references. Thank you. Stop video.